I just wanted to discuss this problem which we face quite often. It's not, this is my financial disclosure. And it's not uncommon to have this coronary artery obstruction, very low in 0.6%, and in valve it's more 2 to 3%. In case you develop this, then mortality is very high, 40 to 50%, despite rescue revascularization. This is the present, this article came into 23 in the Journal of American Journal of Cardiology Interventional, and this showed that they predicted that new model, traditional model like height more than 11 millimeter, SOV less than 31 millimeter, residual SOV 5 millimeter less. These are poor sensitivity and specificity. They studied 60 patients who had angiography obstruction after Tavr versus 1,381 patients who didn't have. So now they predicted it's better predictor for this obstruction is cusp height. Coronary cusp height more than coronary height, that chances of obstruction is more. BTC equal or less than 4 millimeter, and culprit leaflet calcium volume more than 600 millimeters. So these three are more important than the traditional height, SOV, all these things. So when you plan for a tower, protection of the coronary sometimes is important. If there is significant disease in left main and ostial stent is already there, then you better protect. If there is an anatomical risk factor based on pre-TAVI echo, CT, angiography, low height, shallow SOV, severe out-eval calcification, high native leaflet length, extreme oversizing, in these cases you should protect it. In valve, more so, similar risk factor, and more so if the valves like mitral flow, trifecta, stentless, then you should protect because chance of occlusion is very high. Just wanted to show you a few cases. This is an 80-year-old lady, critical aortic stenosis, tricuspid, and narrow, small annulus, 21.5 millimeter, and SOV is again small, 25. Coronary height, left coronary is 7.9. So these are the things, challenges. Left coronary height 7.3, low, and SOV diameter is 25 millimeter only. So upfront we decided to protect the coronary, and this is what we did. We just dilated with the balloon to check. There is some slow flow in the left coronary during balloon dilatation. So we decided to park a LED stent 4 into 15, and after that we stented. The patient had a hypotension, bradycardia, and there is some slow flow in the left coronary system, so we decided to put the stent 4 into 15, and then after that the result was very good. And this was because of the low coronary, small SOB, narrow SOB, we decided to protect it and put the stent required. This is another patient, 76-year-old female, again critical aortic stenosis, and annulus was 22, and SOV was again small, narrow, and coronary height was again left coronary was 8.3. So challenges were coronary ostia 8.3, borderline RC height, SOV is 24.8 only. So decided we'll wear the LED, and this is that's the pre-dilated, and you can see there is some suggestion that probably it's occluding, and we put a my valve here, and after that you can see it, there is some, that leaflet is just occluding the left main ostium, and we put the 21.5 my valve deployed, and then we put a stent 4 into 12, very small stent, which migrated. So we put one more stent, 5 in 12, and that's the result. So this is actually two stent. We should have put a little bigger stent from the beginning, but we took a small one. That's why I missed. This is just another case, a 72-year-old female, again critical aortic stenosis, and annulus is okay, but this was the challenge was left coronary height was 9.3, and this is the very small annulus. Left coronary was 9.3, and risk of coronary occlusion was there. So we decided that we dilated. You can see there is a little obstruction. Flow is definitely reduced in the left coronary, and you can see it. So because of the low coronary, small annulus, we had decided to take a accurate neo, because the upper crown has a T2 tendency to put the leaflet down. You can see here we have taken, during balloon dilatation, there is definitely reduction of the flow into left coronary. So anyway, we dilated, we deployed the valve, and then after that we checked. Flow was very good. We pulled out, we didn't have to put the stent. I think this accurate neo upper crown pushes the native valve down, so it protects the coronary, and chances of coronary occlusion is very low. So that's why we decided to use this, and narrow annulus also. And this was the result. This is the last 51-year-old male, bicuspid valves, severe LV dysfunction, and we decided we sent him for surgery, but he was not willing surgery. Surgeons also was reluctant, and these are the pictures. Coronary height was okay, but type 0 bicuspid severe aortic stenosis, and we decided to use a Sapien 3 valve, and this is what we did. Dilated, pre-dilated, then we balloon. You can see during balloon inflation, flow is there, it's not reduced. So we decided that we'll not protect it, we'll go ahead and implant the valve, and this is after the implantation. This is what happened. The left main totally occluded. We were lucky we could cannulate the patient immediately and save the patient, and ultimately put a 4 to 12 drug stent and save the patient. Patient had a cardiac arrest, and we ultimately. So I think very important that, especially in bicuspid aortic valve, when there is borderline, you should protect the coronary. Even in borderline, also no harm in protecting and making its procedure safe. This is the last injection. So in high-risk cases, especially in low coronary, small SOV, bicuspid valve with large cuffs, it's important to protect the valve. There is a potential role of angiography during balloon valvuloplasty. Consider reposition of Tavr system, and probably accurate neo in small coronary is a good option, because this has a mechanism to put the native valve down. And a simple city-based prediction model using cost height, VTC, and leaflet calcium volume performs well in predicting coronary obstruction, including coronary height and SOB width. So I think it's more important that you should look at this newer like cost height, VTC, and leaflet calcium measurement to predict the coronary artery occlusion. Thank you very much.